All right, everybody. So this is the August 8th, 2023 clinical case review.
I'm going to go ahead and get my slides up. I think everybody knows the routine. We have some new faces here, but today, every other month, we do clinical case presentations. So I'm going to talk about a patient that we saw in the clinic, and what we try to do is sort of share with you different case studies to give you insight in terms of exactly what we do with patients and what our thinking is. Just another perspective in terms of our approach to medicine. One of these days, I'll do an overall lecture or discussion on my philosophy and our overall game plan of really switching the way we practice medicine, have a different take on these things, because practice of medicine is, I think very inadequate, to say the least, in the allopathic space. And even for the very sick patients, we're not doing the types of things to definitively turn them around. So more about that later. But as for today, let me share my screen with you. And we're going to talk about a patient who we saw who came with some cardiac issues. And we're going to talk about improving cardiac structure and function with lifestyle. So essentially, if you have a weak heart or a diseased heart, is there a way of controlling things? So this patient is a 70-year-old man with high blood pressure. He was seen in the emergency room prior to seeing us with a blood pressure of 200/100, which is extremely high. He was treated emergently in the emergency room. Typically, they use clonidine, which was used in this case. So they'll typically give them something, get the blood pressure down, make sure they're not having a heart attack, and send them out of the emergency room. So he was discharged on amlodipine 10 milligrams and was told to see a cardiologist, and he came to see us. And there's just a little graph showing you different classification of blood pressures. And of course, he was clearly in the hypertensive crisis range, although he didn't have any end organ damage. So it technically didn't get called crisis. So we saw him.
What kind of medication is clonidine?
Clonidine is a central alpha blocking agent. It works inside the central nervous system and blocks, essentially reduces the overall adrenaline output from the central nervous system.
Okay.
And oftentimes when people take it, they can get drowsy or maybe headaches. And I don't like it as a routine drug, but they give it routinely in the emergency room on an urgent basis. I think it works okay from that standpoint, but we try to wean people off of it as soon as we can. So we saw him, we draw blood on the first visit. He did have some evidence of kidney renal function, chronic kidney disease. GFR is 53, it should be greater than 60, and even ideally greater than 90. He had some evidence of stress on the heart with a slightly borderline elevated troponin level. He's had inflammation, and his lipid panels were off, some plaque inflammation in the blood vessels, and high cholesterol. So essentially, here's somebody that had hypertension, and he probably had, coronary disease and vascular disease. So essentially, the lab finds indicate atherosclerosis, and here's a little diagram showing that process. Starting with the normal artery starting here, you get first endothelial dysfunction. The muscle walls usually get thicker and hypertrophy, usually before you get stenosis. This is just showing more stenosis first. But this is the progression of atherosclerosis, which is likely what was going on. And he could have had anywhere along these lines here. He has ejection fraction was only 45%. So his heart was mildly weak. It was also a little bit stiff. We call that diastolic dysfunction. And his heart was hypertrophy, so it was a little bit thickened as well. Hypertrophy is just thickening heart muscle. His heart was working against elevated blood pressure for a long time, so it makes it thick and stiff. And if it's long enough, it starts to make it weak. So he had early signs of heart failure, early signs of kidney failure, and blood vessel disease. So he really wasn't healthy, even though he presented to the emergency room with just elevated blood pressure. He wasn't quote unquote acutely ill, but he had a lot of things going on underneath the hood. The EKG showed some baseline abnormalities. These are T-wave inversions, and really it's more consistent with abnormal blood flow, which you call it ischemia. And this is at rest. So yeah, the ischemic change at rest. When he exercised, blood pressure went up to 220/110. This is stress and exercise. Camille likes to comment on the pseudo-normalization when it goes from inverted to upright, which is defining. Some people debate whether it's true ischemia or not. I think it is more ischemia when it has that pseudo-normalization, but we know he has resting ischemia. So we know he has coronary disease based on EKG, based on one of the biomarkers called a plaque 2, which shows there's inflammation in the vessels. And his cholesterol and blood pressure elevated, which are two major risk factors for coronary disease, and he has mild heart failure. So this person is somewhat a walking time bomb. He can have a heart attack, he can have a cardiac arrest, he can have a stroke almost at any time. However, despite all those problems, the most definitive thing for this patient would be lifestyle change. So for instance, if I were to take him to the cath lab and do a coronary angiogram, probably 60%, greater than 60% chance we find that he didn't have enough coronary artery blockage to warrant doing a stent or bypass surgery. And then also taking him to a heart cath would put his kidneys at further risk for further damage. So we tend not to jump to these procedures right away. He was more or less asymptomatic, and he really needed a lifestyle intervention. Putting a stent in an artery is not going to, fix all of his problems. It'll probably make things worse. So, elective revascularization was not a good choice because it has increased risk. In his case, worsening kidney failure. It doesn't reduce mortality. It doesn't reduce the risk of a heart attack in the future. So the only thing it would do is treat symptoms, and he wasn't having symptoms. So if you have a loved one, the doctor, cardiologist said, well, you need a heart cath and not having symptoms, then you probably should question that and find out exactly what they're trying to accomplish. So anyway, so we decided to go with lifestyle change, and you can all guess, put them on a raw detox plant-based diet. And you see the delicious options you had there. Of course, no oils, seeds and avocados are sorts of healthy foods. We put them in infrared sauna therapy that also helps the body produce nitric oxide. It also helps with improving blood pressure. So you start having lower blood pressures with sauna in the detox diet. When it was previously like 150/90, went down to 130/80. Now, initially, he became a little bit dehydrated. His creatinine went up, and a lot of that was the sauna. He probably wasn't hydrating. So when we rehydrated, creatinine came back down. And I suspect this can get better. GFR went up and bounced around a little bit. His C-reactive protein reduced a little. ApoB came down. The plaque 2, inflammation of arteries improved. Cholesterol improved. This is all in about post-detox, which is typically about 4 weeks that we had him. And plus the blood pressure improved. So LDL cholesterol went down by 50 points, and C-reactive protein went down. And these are the things that the particular C-reactive protein is a risk factor for infarct. Now, we want to improve his kidney function, make sure he stays hydrated. And his ejection fraction got better. So that's a good sign that things were up and the blood pressure came down. This is probably correlated to reduced blood pressure because you have decreased blood pressure, decreased afterload stress on the heart. So it can pump out a greater percentage of blood. And so he continued the infrared, continued to eat.
What ejection fraction do you consider normal?
55 is normal.
Okay.
Yeah, so it went from mildly abnormal to back to normal. So essentially, this patient had a quick turnaround and avoided being sent to the cath lab, which is very important in his case because he had compromised kidney function, which, had we taken him in, done these procedures, and maybe we would have found something that required a stent. We didn't put him, then when he got in the stent, then he had to be on Plavix. And maybe, future events he could have had needed future angiograms, or maybe he could have had to stay in the hospital due to, renal dysfunction. So he's still a patient that was going to need more intensive treatment, but not so much in the hospital, but more outpatient. He may be a candidate for ozone therapy. Well, he's definitely a candidate for ozone therapy as well as plaque RX. Plaque RX is a form of phosphatidylcholine. We give infusions, and that can actually literally open up the blood vessels, and also it's good for improving kidney function. So someone like him would be a great candidate for plaque X. Now, at this time, we didn't have those agents in, so I'll have follow up with Camille and see where he is and see how he's doing. And if his kidney function is still questionable, we may recommend plaque X infusion. So that works quite well for that. So that's a situation. Any questions?